Good afternoon, Africa. Welcome to another exciting edition of Shalina Global Webinar Series, connecting Africa to healthcare communities to the rest of the world. Thank you for being true to your word and staying true to us all these years. This panel discussion, though a hybrid one, is brought to you by the Shalina Academy. I did like to tell you a bit about Shalina. Shalina Healthcare is one of the largest pharmaceutical companies in Africa, with over 40 years of corporate legacy in sub-Saharan Africa. Throughout these years, we have stayed true to our founding principle of quality, affordability, and availability. Thereby, through these principles, we are making access to healthcare a right for all Africans so they can lead a healthy and productive life. We do this by offering Africans an experience of having products manufactured in WHO-approved facilities in Asia and in Africa. Today's hybrid webinar series, we will be looking at a panel discussion to mark the World Malaria Day for 2022. Today's topic will be malaria control in sub-Saharan Africa. We'll be looking at experiences. Our panelists will be telling us, sharing their experiences, and also they will be bringing their wealth of experience to also share their perspective. This is coming to you from the brand that promises to knock out malaria in 3 days. No other brand can do that, but Charlatan. Allow me to introduce our erudite scholars in the house, our panelists already gearing to go. Allow me to bring on set Professor Olubinga Ayodeji Mokolusa. Thank you for being here, sir.
Thank you.
Sir is a professor of pediatric and child health from the University of Ilorin Teaching Hospital, Nigeria. Sir is the current Malaria Technical Director and National Malaria Elimination Program. He has over 25 years experience in malaria and neonatology and public health. Sir is a vast scholar. He has chaired the technical expert group on WHO anti-malaria treatment guidelines released by WHO from 2017 to 2019. He has also facilitated the release of over 2 billion cumulatively in support to many African countries for the fight against malaria. That's huge. Sir has also directed the national and zonal training of trainers in malaria case management, producing over 1,320 trainers in Nigeria. His scientific contribution is also huge, as he has published over 90 papers in reputable journals. In 2021, he was listed in the United Nations New York Photo Exhibition of Champions to End Malaria. He was the first runner-up of the British Medical Journal Award for the Best Research Publication, and is also a joint winner of the 2017 LNNG Prize for Science in Nigeria. Welcome, sir. Great to have you on set.
Thank you very much, and pleased to be with you, listeners and participants on this webinar from all over Africa.
Thank you so much, sir. Also here with us is Mosumola Dosumu. Please join us on set. Great to have you.
Thank you very much.
Great to have. Ma'am is Assistant Secretary of the Association of Community Pharmacists of Nigeria, popularly known as ACPN. She is an executive pharmacist of HealthServe Plus. She is also the host and producer of an online and on-site public health initiative called Health Vibes with Mosumola, such a buzzing page on Facebook. She has special interest in malaria, drug abuse, epidemiology, digital health initiative. Her responsibilities are huge. She has initiated an online project on drug abuse called Project RX. She's also a member of the International Menopause Society. She is an alumnus of the prestigious Lagos Business School, and she has been awarded with scholarship by the Rotary Club to Illinois in the United States of America for a 1-month exchange program. She has also started a postgraduate course in mass communication and marketing at the Rome Business School. Join me in welcoming Fam Musumola. Thank you for joining us.
Good afternoon, everybody. It's a great pleasure being here.
Also here is Dr. Yetunde Ayo Oyalo.
Good afternoon, everybody.
Thank you. Thank you for joining us. Dr. Yetunde is the CEO of Market Doctors in Nigeria. She's also the senior partner at the Preventive Health Managers. She's the convener of Doctors That Discuss Malaria, and she also has a healthcare leadership certificate, and also she's regarded as a social entrepreneur. And she has a social entrepreneurship program called INSE. Her contribution to society is vast, as she has pioneered many health programs, including school health clubs in over 10 schools. She has also facilitated training for more than 200 medical staff and hospitals for our Spirit to Excellence program. She has recently executed a USADF, that's United States African Development Foundation project in partnership with Lagos State Employment Trust Fund to provide employability skills to Lagos State youth. She is also a recipient of the prestigious award of her network, that's the Woman of the Year Award by Fidelity Bank and also a Fidelity Bank Most Prestigious Innovative Business Award. She is also a member of the AGPMPN and also has earned an award of AGPMPN Most Innovative Healthcare Business Award. Thank you for having me on set.
Thank you. Thank you for having me.
Great. We'll move on today. Like I have shared earlier, today's program promises to be quite exciting, and we're looking forward to get going and to share from the experiences of our erudite scholars. Prof, I'll be letting you take charge of the discussion from now, while we learn from our scholars. Thank you so much.
Thank you very much. We want to welcome every participant to this webinar. I think the first thing we would like to do is to set the stage by giving us some high-level summary of the malaria situation, both globally as well as in sub-Saharan Africa. We will try not to be overtly technical about this, and we'll just keep it short and simple, as they say. But I welcome you all from the different parts of Africa, and they're listening to us live from the Shalina Academy studios. Now, the first thing I'd like to do is to give a brief on malaria situation. First, I would like us to know that malaria remains a major killer disease. The WHO 2021 World Malaria Report shows that globally we still have about 229 million cases of malaria, and we have stalled a bit in the progress towards our targets for eliminating malaria in the last few years. But sad to note that about 94% of all of this malaria occurs in sub-Saharan Africa, and just a few countries, with Nigeria accounting for about 27% of the burden. We have Democratic Republic of Congo accounting for 12%. We have Mozambique accounting for 5%, Uganda 4%, and just a few countries actually account for 50% of the malaria that we have in sub-Saharan Africa. The fight has been on over several years, and in the area of mortality, we have over 400,000 deaths occurring due to malaria. Again, most of these, over 90% from sub-Saharan Africa. So we can see that Africa is disproportionately hit, really, by malaria. But the good news is that malaria used to be pretty high in some other parts of the world, and over time, they have been able to gain control and to bring malaria down to the point of elimination. And that tells us that it is possible to achieve elimination, and this is the reason why we're doing what we're doing as we mark this year's World Malaria Day, and we're reviewing this particular presentation on challenges and experiences with respect to malaria control. Now, specifically, we have 5 different types of organisms that cause malaria. They're called Plasmodium species, and these include Plasmodium falciparum, which causes the majority of the malaria that we have, as well as the most severe forms of malaria. You have Plasmodium vivax. The contribution of vivax has reduced from about 7% to currently about 3%. One rough way of trying to remember is that where there are black people, you find falciparum, and where the skin color is a bit lighter, you are likely to find an increased occurrence of vivax. It may not be the dominant one, but an increased occurrence of vivax. Then we have Plasmodium ovale, Plasmodium malariae, and in forested regions of Southeast Asia, we also have Plasmodium noci. So these are the various causes, and to give us some perspective, our efforts at controlling malaria is multifaceted. What we have learned over time is that no single strategy is sufficient to control malaria. So the current efforts is an integration of different strategies. I'll break it down into a very simple outline for us. So one is that we should remember that malaria is ultimately the product of man, his activities, interaction with his environment, where you have the mosquito, and then you have the conducive environment for producing the larva that transmits into that mosquito. So whatever we do, we have different approaches for the malaria control. So we can divide it into the following headings. One, vector control. Okay, mosquito is the principal vector that facilitates the transmission of malaria, and so we have strategies for vector control. These strategies collectively are called integrated vector management, but specifically comprise of the use of insecticide-treated nets, for which people are recommended to sleep under insecticide-treated nets each time they are sleeping. And then we have the indoor residual spraying, in which houses are sprayed with specific insecticides that last over a variable length of time, between 6 months to 1 year, and then they have to have repeat sprays occurring. And you now have other complementary activities for vector control in terms of environmental management, and then depending on where we are specifically, there could be complementary activities like larviciding. So that is vector control. Then we have chemo prevention. Chemo prevention is the use of medication to prevent malaria from occurring. Slightly, okay, it's encompassing, but a bit different from just the isolated use of the word chemo prophylaxis. So in chemo prevention, we have chemo prevention in pregnancy, chemo prevention in infants or children, which is called seasonal malaria chemo prevention, and then we have intermittent preventive treatment in infants. And then in special population of people moving from area with no malaria into an area with high malaria burden, we have chemo prophylaxis. And in specific population groups like sickle cell disease patients. We also have chemo prophylaxis. Then we come to the third leg of the control of malaria, which is diagnosis and treatment. And just as that implies, it is effort to recognize the parasite and then to give treatment, which is ACT, and then to treat severe malaria where it occurs, preventing mortality and limiting disability generally. When we have done all of this, then we have additional tools in terms of monitoring and evaluation so that we have our figures to know whether we're succeeding or not. And we have government policies and funding, which is very critical to the overall malaria goal. So basically, this will be malaria in brief, and I think we can set the stage with this. I will call on my other colleagues to also speak briefly over the next 2-3 minutes about their area of activity that they bring on board in this conversation. So first I'll call Pharmacist Mosumola. She will be talking to us a little bit from the perspective of a community pharmacist and their role in the fight against malaria. Thank you.
Thank you very much, Prof, for that wonderful summary. In the next few minutes, I'm going to be talking to us about the role of pharmacists in the treatment and management of malaria. Pharmacists generally appear to be one of the most accessible healthcare professionals. We are experts when it comes to the use of medications, thus making it the right parameters, the right partners for the prevention, control, and treatment of malaria. Pharmacists possess knowledge and skills required to ensure safe and effective use of medicines. Pharmacists are responsible for the supply of medicines and the counseling of patients and their caregivers. Community pharmacists are becoming increasingly involved in health promotion and education. All these roles are targeted at helping clients to achieve optimal outcomes from drug therapy and to make sure that clients live a healthy life.
Thank you very much, Pharmacist Mosumola, for that. So we are beginning to see that the malaria fight is everybody's fight, and we can hear the important role of the pharmacist in this battle. Next, I'll be calling our third panelist, Dr. Yetunde Ayoyalo, for her to bring to us another special perspective. She's a strong person on community interventions, and she'll be speaking to us also to introduce what that brings on board in the fight against malaria across Africa.
Thank you very much, Prof. And thank you, Pharmacist, for contributions. And just to say that I'm really happy to be here. And I hope everybody online is enjoying what we're doing. Try as much as possible, to speak in a language that you will understand. Talking about community-based initiatives, our work in Market Doctors is actually to get help to people fast and to bring it to their doorstep. So what we're trying to do is to get access, give people access to health and make it fast and bring it to their doorsteps and not affecting their economic activities. How does malaria come in? Malaria is a disease that is such a burden, to us in Nigeria and in the entire sub-Saharan Africa. When we look at malaria, a lot of us look at the discomfort that comes with being ill or having fever. Most of us, when we are ill, two things drive us either to the hospital or to the pharmacy. It's either there is a fever or there is pain. When there is any of these two, we want to get out and talk about it. So the burden of malaria is so high. And when we're talking about community, there are communities that don't even have access to pharmacies or healthcare providers. Either that it's too far or they have to spend money to get there. So there are a lot of things that is being done at the community level. And like Prof said, a lot of the things we can do about malaria are actions that we can actually take ourselves In the area of prevention, there are things that we can do ourselves. In the area of information, communication, educating people, there are things we can do by ourselves within the community. But most of the time, largely, what we found out is that if we want to fight malaria, and we just bring our methods to the community without actually letting the community members take part in the process of bringing this to fruition, then what we do not really make a lot of impact. So in the fight against malaria, in prevention, we have to have messages that the people in the community can understand. The messages have to come, of course, in local language, in pidgin, sometimes in even other forms, maybe songs, drama, sports. All of these things have to come together to help us to fight malaria. We also need to know that there are key stakeholders that are needed in the fight of malaria. We need our community leaders, we need our pastors, our imams, our traditional healers, we need our teachers, we need our children who are actually a focal point of taking the message from the school even to their families. And the families, there are some families that can act as model families, in this fight against malaria. So I'll speak to the social part. What a lot of us also have to know is that malaria creates a huge financial burden on the family. Besides the stress of, oh, I'm ill, I have fever, it creates a huge financial burden on the family, meaning that they have to buy drugs. And if the treatment really needs the person to be admitted, it means someone will not go to work. And this falls on the woman, and I'm passionate about women. So it means that the woman is going to act as the caregiver, take care of the child or any of the family member that is ill. So there is a lot, that the community can do in the fight against malaria. This we've been doing by providing medical outreaches and also teaching, educating people on what they can do against the fight for malaria. Thank you very much.
Well, you have it. That's an array of involvement of everybody, and you can see that malaria touches everyone, and we are in this together. So over the next few minutes, we shall be going through a number of questions that have been posed to us. And I want to encourage those that are listening to us to look out for the various social media handles that are related to this webinar. And you can send in your questions on the various platforms. They are being monitored, be it Twitter, Instagram, even emails. Just send in your questions. We shall be looking at them, provided they have not been answered. But we'll go through a set of panel questions, and together with my panelists, we will be trying our best to discuss this. So the first question we have, and I'll be calling on Dr. Yetunde to deal with that. You have just started mentioning it, but maybe now you have a little more space. How does malaria affect sub-Saharan Africa?
Thank you, Prof. And like you said, I've already started talking about it. One major area, like I said, besides the stress of being ill, the problem of being ill, and even the fact that it kills, is that it slows down the economic growth. In sub-Saharan Africa, it slows down the economic growth. Anytime we have to spend money on something that can be avoided, then of course it slows down our economic growth because it reduces our purchasing power. And we know that a lot of us, those listening, spend for malaria. So if you have malaria, it's most likely you take your money to the pharmacy or you take it to the hospital. So you're going to spend out of the cash, the disposable cash you have to treat malaria. And in a lot of families, every month they are spending on malaria. Even sometimes when they don't, in quotes, have malaria, they feel I have to treat malaria every month. I've not treated it every month. So it slows economic growth. And we've seen that about 40% of healthcare costs, if you think of what you spend money on, every month, if you look at what you spend on health, about 40% of it is going to be spent on malaria, and it's going to be either direct or indirect. So you go to the grocery, you are going to buy insecticide treated nest, you are going to buy a spray, you are going to probably buy a mosquito repellent, you are going to spend money putting mosquito net. If you rent a new house, you're going to spend money putting mosquito net at your door, you're going to put at your window frames, so it's a lot of spending, and like I said, it slows down the economic growth in the family. Even when you look at between the poor households and the rich households, it's the same story, because the factors that make each of us have malaria are around us, and we know that it is endemic. In women and children, it reduces the quality of life. Children cannot go to school when they have malaria. When women are ill, they cannot make income when they have malaria. When the men are ill as well, they cannot provide for the family. So it slows down the life in the family and reduces the quality of life. And that's when you see people say things like, "Oh, I need some money because I've been treating malaria." People come to even request for health loans. I'm sure some of us receive text messages. "Oh, my daughter has this, that. I need money to purchase drugs." That is the kind of effect that malaria has, on the family. It causes loss of income, because we see that a lot of us, spend our monies, and when it's not properly spent, because that is what we're going to be learning here, on how we are supposed to allocate our money, our resources in treatment of malaria and in preventing it. Those are part of the things that we're going to learn here. Of course, our treatments are affected by our geographical location and socioeconomic factors. For those who are, it makes the poor go poorer, because they're not close to healthcare facilities. They do not get good healthcare. So they may start from the level of my next door neighbor before they get to a chemist, before they get to a pharmacist, then before they get to a healthcare provider. So looking at it globally, it causes a loss of productivity, and this is really a major problem. Looking at the fact that a lot of money is spent on prevention, treatment, diagnosis of malaria, which could otherwise have been spent on other things. Thank you.
Thank you so much. So we can see malaria with its devastating effect across Africa, cutting across social, financial, economic, and other aspects of our life in Africa. Now, some people do think that they acquire malaria by walking under the sun and several other beliefs. May I ask Pharmacist Mosumola, please, how do people acquire malaria?
Thank you
Or
very
is
much, Prof.
malaria transmitted?
Recently, somebody asked me a question and said, "Is malaria transmitted through kissing?" Malaria is not transmitted through kissing or hugging. Malaria is simply transmitted through the female Anopheles mosquito. When the Anopheles mosquito bites an infected person, it picks up the parasite from that infected person, transfers it to another individual, and this infected parasite gets deposited into the blood, moves from the blood into the liver. From the liver, it gets multiplied, and it can easily be picked up by another mosquito. And most of the time, you see that in a family, if you have children, maybe like twins of different ages, children of different ages, when one falls sick today, in the next 3 days, you see another person getting sick again. Maybe the father will catches it, the mother picks it up, which means it's the same infected mosquito that is being transferred from the father to the mother to the children. But this can be stopped. We're going to get to know more about how this can be stopped. Thank you very much, sir.
All right, thank you. So, a major symptom of malaria is fever. And the question with me is, how do you differentiate malaria from some other illnesses? Okay, now several illnesses and several disease conditions also present as their main symptoms. So the question is, how do I tell But let me state up front that from just the symptoms alone, it's really very difficult to tell what is malaria and what is not malaria. I would like to state this for our listening audience because several people have their own combination of symptoms by which they are so sure by experience over time, and they lay claim to once I have this combination of symptoms, I'm definitely certain it is malaria. Nothing can be further from the truth. However, on a general note, malaria will present with fever. There could be weakness, the vomiting, such types of symptoms, a feeling of being unwell. There could be some joint pains, but I'm saying to us, all of these symptoms are not unique to malaria. So it's really difficult to differentiate on the basis of its manifestation. There are a few types of characteristic fever that will be going a bit more technical, but that informs some of the ways in which the health worker asks us questions so that in their mind they are trying to sort it out whether malaria is more likely or some other conditions are more likely. Another thing that we do is that if we are able to readily explain the source of the fever, then we may say it is not malaria. For instance, if somebody has another injury, if the person has some skin condition, and we can see that, then we say, oh, the fever is because of that. So, but I think we can rest it here to just say that it's difficult to tell which fever is malaria, which fever is not malaria, and that brings us to the question of testing. So we will be arriving there, but I think that is sufficient for now. So, and when we talk about testing, so the next question really is how then do we test for malaria? Uh, so there are different types of tests, many of them, but for our use on a general note, I think there are two tests that are of importance. One, the malaria rapid diagnostic test and malaria microscopy. So malaria microscopy will be done by somebody who has been trained and retrained and particularly recently trained. Okay, and I mean each of those areas because one of the biggest challenges with malaria microscopy is the quality of the microscopist, all right, and the capacity. There are other things about quality assurance, but we leave that as a technical conversation. So more commonly available to us is the malaria rapid diagnostic test, which can be done by anybody from the proprietary patent medicine vendors to the most high-level physician that you have. So anybody can do a malaria rapid diagnostic test to have results available at the point of consultation in order to inform the decision about malaria. I know that you are eager to hear and to confirm how reliable is the malaria RDT. Spare me your bullets. We will come to that and try to address some of your popular concern in that regard. But allow me for now to raise the question, which I'll call on another panelist to answer, that when somebody has features that to all intents and purposes you are going to say, oh, this is malaria, but then you do the test and the test is negative. What do? Pharmacists will say that you see people who come in your practice. So tell us, what should we do?
Prof, I must tell you that this is a very, very difficult one. Very difficult one. Out of 10 people coming into the pharmacy, 4 or 5 of them are coming to you, telling you that they have malaria symptoms. And all they're interested in is getting results. Most people are not even interested in being patient to get the use of the RDT. But from what Prof has said now, I will encourage everybody out there. Once you get to the pharmacy, you must get tested. Insist, tell your pharmacist that you want to get tested. These kits work. And once you do the test and it tells you negative, please believe it, you don't have malaria. What that means is that your physician or your pharmacist needs to ask you more questions, needs to find out about the history. That tells you that there is no comorbidities, that there's, well, let me come down to your level, which means that there are some other there's some other infections or diseases that needs to be considered. Those days, I remember somebody walked into the pharmacy and we did the test and it shows negative. The person said, no, I have malaria. I'm having high fever. I'm having chills. No, you people don't know what you're doing. Please accept it now. The RDT kits work. And as from this moment, insist that you want to get tested. Once it is negative, you don't have malaria. Don't let anybody overload you with anti-malaria. Thank you very much, Prof.
All right, so thank you very much. We have had, as we said, there are more things that cause fever than than malaria. So when your malaria rapid diagnostic test is negative, it means that we have to look for other causes of fever. Recently, our world was plagued with COVID, for instance. That was a great opportunity for us to be able to identify people who might have had another infection that is not malaria. And so you have multiple causes of fever. You have febrile illnesses, you have bacterial illnesses, you can even have some other chronic conditions, malignancy, drug reactions. So there are just too many things that cause fever. And our message to us today is to believe the malaria rapid diagnostic test results. Now, on this account, let me explain further to us that the way the malaria rapid diagnostic test works is very simple and we can understand it. So essentially, you have a platform that is called a nitrocellulose paper, and on it is already embedded certain chemicals that are in form of lines that appear on that rapid test. So when you pass blood through that particular test, those lines show up. And the good thing is that irrespective of who you are, for as long as there is sight, then you can see the lines and you can know whether the test is positive or negative. Many people have been embarrassed by the fact that when they start doing RDT, they find quite a number of negative tests. The truth of the matter is that we have been over-treating malaria many times. So let's be humble to accept that maybe we have been over-treated, and instead of saying, oh, it is the RDT that is not working. Some will say, oh, but we did a test, it was negative. And then we went to do microscopy, it was positive. In very, 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 very extraordinary circumstances, that is a possibility. But the first question, as I'm telling you, is that what is the competence of that microscopist who did that test? So let's believe more on our RDTs. I'm not saying over the microscopy, but I'm just saying that RDT is an independent test. Okay, it's reliable. Please follow the result of your RDT. If you happen to be opportune and the microscopy was done in a reliable context, also believe the result of your microscopy, but don't discard an RDT result just because you felt otherwise. When you start testing it, you'll be shocked at the reduction in the number of positives actually, and that may reflect a true situation. All right. If there are other questions, you post it. I think we will pick it up and still try to trash it. So having spoken about this, the next question that confronts us is that how do we prevent malaria? And I'd like Dr. Yetunde once again to talk to us about our options for the prevention of malaria.
Thank you, Prof. Prevention of malaria is everybody's business, and I know that typically a lot of mothers take it upon themselves, and it's repeatedly, they say it, don't catch malaria, do this, do that, because everybody knows that people get malaria almost at the slightest thing. So to prevent malaria, I think we'll look at it in the usual fashion, ABCD, so that we can actually remember. First of it is creating awareness. It's everybody's business to let people know, to create awareness about malaria, malaria prevention, the risk, the symptoms. It's simple. It's what we all understand, and the reasons why we need to prevent ourselves from having malaria. We can say that it doesn't concern me, but we know the way we live in Africa, we cohabit a lot. So the habits of the next person can actually affect you. So it's everybody's business to create awareness about hygiene and all of that, all the things we need to do. So bite prevention will be the key. We have to prevent ourselves from being bitten by these mosquitoes. And we are aware that they are around usually from dusk to dawn. That is from the evening to the morning. That is when we get a lot of these mosquitoes, around. So we need to protect ourselves by sleeping under the nets. I know a lot of people, don't like sleeping under the net. They tell, it's so hot to sleep under the net and all of that. And I've also seen communities where when they even give them nets, they use the net for their farms. They use it as scarecrows, they use it for other purposes. So please, we need to see. There has been a lot of nets distributed, in sub-Saharan Africa. So we should sleep under the net, especially pregnant women, children. Then, of course, the hygiene is important. We know how the vector breathes. It breathes in stagnant water. So it's important by environment clean. We shouldn't have stagnant water here and there. I know that there are a lot of things, that have to do with this, because in a community where there's no water, people tend to store water, and all of this creates breeding spaces for mosquitoes. So it is, like I said, creating awareness is everybody's business, and creating awareness about what you do and what your neighbor does that would affect you. Then, of course, there is also the one of the C, we call it Chemo Prophylaxis. Means there are some drugs that can be taken to prevent malaria, especially in pregnant women, and during antenatal care. And for people who want to travel to malaria endemic areas, there are drugs that can be taken that will prevent them from having malaria. So you need to talk to your healthcare provider, and they'll be able to advise on which one to do. Then, of course, there's diagnosis, which Prof has emphasized that we must test. It's very important we test to avoid over-treating. Some of the monies we are spending on malaria medications and all of that are not necessary, and the reason is because we are not testing. So like I said, it's everybody's job, advocacy. We must try to educate people around us and tell them things to do, especially in terms of hygiene, sleeping under the net, bite prevention, why we do not want to have malaria, want to prevent malaria. Thank you.
Thank you very much. So let's assume that we have gotten tested and it's confirmed that somebody has malaria. What should we do? Let me once again ask Pharmacist Musimola to take us through that.
Well, thank you very much, Prof.
What treatment should we get?
The approved therapy for malaria is the artemisinin-based combination, and they have the different classes. They have the artemether plus lumefantrine. You have artemether and amlodipine. Artesunate and amlodipine, and dihydroartemisinin. Gone are those days when you use monotherapy. In those days, I remember that we used to use the treatment of Fancida. That's one monotherapy. Gone are those days anymore. Right now, we have artemisinin-based combination.
Thank you very much. So ACTs are the recommended treatment for uncomplicated malaria. There is no need to say you are starting with an injection or things like that. Uncomplicated malaria should just be given ACT and you take it for 3 days, such that even if okay, let me just ask you. Sometimes you take ACTs and after 1 day you're already feeling fine. Should I discard and discontinue the ACT or what should I do?
The ACT-based combination is a 3-day treatment therapy. You have to take it for 3 days. If you think that, or you feel that after 2 days you are fine, you're well, you can go about your business, you're doing yourself a great harm. Why? After the 2 days and you stop, malaria parasites, now they have developed a lot of wisdom. They are wiser than human beings. After the 2 days, the level of the parasite has been reduced to a certain level. The lower level that has been left untreated now start multiplying. And when this multiplies, it now goes through another cycle, and then maybe a few days after a few weeks, you fall sick again. And this can actually give rise to treatment failure.
So thank you very much. So it's dangerous.
Very, very
Very
dangerous.
dangerous for us not to complete our 3-day treatment.
And you end up spending more money.
Okay. So you have the problem of recurrent treatment because of partial treatment, and then the propensity for the development of resistance by the parasites. So thank you very much for that. If you are taking your ACT, take it for 3 full days. All right. So sometimes, the medical people talk about severe malaria. So, Dr. Itune, what are some of the red flags that should also make us know that it's no longer an issue of you and your pharmacist? It's now an issue that requires some additional care. You have gone beyond your primary level care giver, whether as a community health worker, community pharmacist, or you are in a primary healthcare setting, and things have developed into severity. What will be some of those red flags that we need to watch out for and to immediately know that I must take this treatment to a higher level?
Thank you, Prof. The healthcare system is in such a haphazard way, where when people have health problems, they go the other direction. You understand? They start from Z instead of starting from A. Normally people start from home, then someone close to them, then probably to the before they even get to the family chemist. You understand? Then there are areas of aunties who are around the area that prescribe and do all of that, then pharmacists, then hospital and whatever it is. But when it comes to malaria, like I said, most people go, the first thing that strikes you when you have malaria, for most people, is the fever, headache. And some people say, oh, my mouth is bitter. That is the thing that really prompts people to go out. But when you start having some other symptoms, and those three, like Prof has said, are not specific for malaria. It could be anything. And thank God for the era of COVID that has shown us that you can have all of these symptoms and it's not malaria, and it could also be any other thing. We're also in the era of self-care, and I think that there's some things people should have. Having a thermometer at home is no longer a luxury. You must be able to say when you have a very high temperature, especially for those of us that have children. When the temperature is as high, it's not something you check with the hand. It's very hot. You need to check and really read. And in fact, many thermometers are now digital. You just read. And when it's giving you things above 30, 37.5, 38, 39, even to some children up to 40, 41, you need to go to the hospital. So the temperature is really a good indicator. And you cannot know it by just putting your hands on the child. You understand? Then, of course, when you also have issues of convulsion, when someone begins to convulse, then it's no longer a case of a primary, a pharmacy, a community health worker, or whatever. You need to find your way to the hospital. Then, for those that some people have very severe diarrhea, accompanying all of these symptoms, and even sometimes bloody stool accompanying all of these features. When we have this, we need to know that we need to go to the hospital. Then for some severe muscle pain, you begin to have really heavy, you can't climb the staircase, And for those who are during the COVID era is when, people really recognize what muscle pain can be, when you can't even, you can hardly do any activity. That can also occur. You understand? So when we have all of these signs, it's time to go to the hospital. Of course, profuse sweating. When you're somewhere, you're sweating profusely, and you know something is going on, you need higher care. So besides that, the headache, the fever, cold shivers are also there. And I'm really interested in, especially in children, because malaria affects children more. And because they can't talk, they rely on us, the parents or people around, to say, to help them with getting access to care. So when we see all of these symptoms, we need to take them to the hospital. Thank you.
Thank you very much. So we have some of the red flags. If we put it together in the malaria balance, there are certain things that we actually call, general danger signs. And some of these have been highlighted. Okay, so when we begin to have a person who can no longer feed, sit, or carry out any activity, completely prostrate, we know that there are red flags there. Convulsions have been mentioned. We have loss of consciousness in any way. We also know that there are red flags that are beginning to be there. These are signs. They're not just limited to malaria, but they are overwhelming signs that the condition that the person has is imminently fatal if nothing is done immediately about that. All right. So thank you very much, my co-panelists, for this conversation so far. That is a question directed at maybe to me as a person. They have asked me to talk about the role of chemo prophylaxis in children. So let me quickly now explain two concepts to us. One is chemo prevention, the other is chemo prophylaxis. Now, in chemo prevention, we give treatment doses of a drug at specific intervals, okay? And we don't necessarily have to wait to confirm diagnosis. It's a different arrangement. It is in the context of prevention, okay? And so that's why we call it an approach, seasonal malaria chemo prevention, which is for children under 5 in areas with high seasonal transmission, where over 60% of the malaria occur within a cluster of about 4 months. In some other countries, like Uganda, the cluster of the rainy season for them is over 5 months. So they are using a 5 month or 5 cycle approach for seasonal malaria chemo prevention, particularly in the Karamoja area of Uganda. All right. But we here in Nigeria, we use the 4 cycle approach, and 21 states of Nigeria come under this approach of chemo prevention. Now, we've heard of intermittent preventive therapy, which is given to pregnant women on a monthly basis. So those are chemo prevention. And there is a form of it also for infants when that's an approved approach. Not yet what we're using, but it's under a pilot trial in Nigeria. Now, chemo prophylaxis, on the other hand, is taking a non-treatment dose of a particular drug that has anti-malaria effect with the goal that the malaria disease will not be established. So in an area where malaria is common, we do not give chemo prophylaxis. But if somebody is coming from an area where there is no malaria into an area where there is malaria, then we give chemo prophylaxis in that instance. Another group of people who sometimes benefit from chemo prophylaxis are the sickle cell disease patients. Okay? Even for them, there are ongoing studies to look at the possibility of sometimes using the chemo prevention approach even in them. But okay, they are one category at least that qualify for chemo prophylaxis. So that's the difference between those two, and I think that should settle us. The previous concept of using Sunday medicine, which is pyrimethamine, that Sunday medicine since about 1970 has been shown to have 100% resistance. So it is completely useless giving Sunday medicine. It's no longer a recommended practice for chemo prophylaxis. Okay. Maybe we just take one more, a few more. Dr. Yetunde, what should pregnant women do uniquely to prevent malaria?
Okay, so pregnant women normally should take all the actions of prevention. I mean, they should sleep under insecticide-treated nets, and they should also go for the antenatal care. One thing I find out in Nigeria is that a lot of women do not go for ANC. A lot present to deliver babies. And even those that go, they don't go regularly. So they present, they register, get their cards, and the next time to see them is during delivery. And that's because there are a lot of myths in the society. The pregnant women, they prefer to put pin on their belly, on their clothes before going out. They prefer to do that than go to the hospital and get the proper antenatal care. They prefer to take concussions that will make the baby's legs strong and all of that. They prefer to do all of that than to go for ANC that will give them proper care. And we know that malaria can lead to abortions, and it's more dangerous in pregnant women than other women. So at antenatal care, by the time they get to the second trimester, they are given a dose of the IBT, and it's usually by direct observed therapy. They're supposed to take it in the hospitals. I don't know how much of this happens, but I mean, to make it effective, that is really what should be done. And they're given this 4 weeks apart during the entire pregnancy to the end. So pregnant women should please take this seriously. We understand that because I know some people will say, oh, it's not available, even though it's been said that this is free. We understand that sometimes there are stockouts in hospitals, sometimes it's not available. And we also know that it's a financial burden, on the family for ANC, but it's extremely important that this should be done. And this is to also add that for men that are listening, if your wife is pregnant, I mean, it's also your responsibility to ensure, that they get proper antenatal care, take all the doses of IBT that is required after the second trimester during pregnancy. Thank you.
All right, so thank you very much. As we begin to try to draw down on this first part of the panel questions, after which we will be going to the second part of looking at many of the questions that you have tried to send in. But maybe in about rounds of 1 minute each, let's say, is there anything that people can do to avoid mosquito bite? Ask Mosimola that question.
Dr. Yetunde has actually answered some of it. Let's look around our environment. Do we have unwanted water in containers, or we have stagnant water? We should make it a routine to make sure that we dispose of that regularly.
And maybe while you're at that, just let us know what can we do to carry everybody along in this battle against malaria.
Okay, we keep gutters clean. We make sure that we sleep, just Dr. Yetunde said that earlier on, we sleep under mosquito-treated nets, and then when we're outside during the nights or in the evenings, we can use repellents. So by doing such, we can keep ourselves from mosquito bites regularly.
So how can we carry everybody along?
How can we carry everybody along? This is part of what we're doing right now. Well, I discovered that the level of knowledge and advocacy out there is really very low. The first thing we need to get across to the public outside is this. One thing I want you to go home with now is this: the malaria test kits, they work. They work. When you get to the pharmacy, anywhere, talk to your pharmacist and tell your pharmacist to please carry out that malaria test. The government should get involved in advocacy. We should talk to the patients. We should talk about it. We should go online, social media. We should talk and create a lot of awareness on malaria treatments. I believe that we can eradicate malaria 100% from our society.
All right, so we are told to spread the news, get it across to everyone, use all platforms, address all groups. Nobody is too small, nobody is too old, nobody is too complicated. Everybody should hear the message. The malaria battle is for everyone. Particularly this year, we're actually saying that every effort counts and we're ready to knock out malaria from Africa. So wherever we are, in some countries, they have gone further to, in fact, make the household the unit of the implementation of malaria policy. And I think that's what we should be advocating for, that we should designate, every household as a household of malaria elimination. Okay, that's where we have gotten to, so that the head of household will become the officer in charge of malaria control in that household. It is that important, and we should ensure that this message goes pretty far. All right. So as I try to bring this segment to a close, gradually some are asking that there are some innovations about malaria. And yes, we're having innovations. What is being looked at is trying to ensure that this innovation is at a density where it can have impact. So we are all aware of the recent development about the availability of vaccine to complement the arsenal in fighting against malaria. It has not been rolled out everywhere, and we're still having all issues around support for vaccine production and being able to meet the need and addressing some of the logistics that goes around the issue of the vaccine. Definitely, that's an addition. It's not going to replace what we're doing currently, but it's going to add up into what we're doing. There are other devices that are being looked at, whether they can be set in households to be able to trap mosquitoes and reduce exposure to their bites, even without the use of nets or indoor residual spraying. Those are innovations that are also coming on board in terms of our malaria fight. And even existing tools are now being recalibrated for effectiveness, better efficiency of their deployment. So it's not a one size fits all. So in some of our societies across Africa where we are interested in justice and equity, don't be too surprised if a particular strategy is implemented in this village and a different strategy is being implemented in another village. We hope that we will have peace and harmony, because what is now being done is to use available information and data to now guide how the tools are being developed in several ways. And there has been a recent commission of a study across African countries trying to identify pockets of innovations that are there, such that if there is any that can be scaled up, then that innovation will be taken to scale for deployment. One thing in malaria is that whatever you deploy, you need it to have a massive effect so that it can bring about an impact. The era of tokenism, of just small here, may not necessarily give us the kind of result we want as we're seeking to march towards elimination. I want to thank you, the audience, for your participation, for listening to this webinar so far. And I wonder to what extent the social media might have been buzzing with questions And so we'll switch on to the social media platform as I welcome Mr. Ayo Akishola of Shalina Academy to also join us in the conversation and to help us retrieve some of the questions from the social media platform. So we'll go into that segment. We are unprepared. We take it as they come.
All right, thank you very much, Prof. And thank you, Africa, for listening thus far. You have sent in questions on social media, and I will be taking them. And I'm sure our panelists will do good justice to this question. The first question coming in, why this person wants to know that ACTs are failing and that the rate of mortality keep increasing, especially in children and adults. So he wonders that why are we not resorting back to the use of chloroquine in African countries to treat malaria?
All right. Maybe I should go for that immediately. ACTs have not failed in any way to that level. Most of what you have had is something called partial resistance. And we have that reported in provinces of northern Uganda. We've had that reported from Rwanda. Okay. But it has not become something at a scale that will justify any increase in mortality. However, the experiences across Africa are slightly different. And it's one, a combination of the use of preventive measures, two, level of early recognition, access to the institution of this treatment on time, and in the event that somebody has severe malaria, what is the capacity of personnel and the infrastructure that is available in order to treat them. So more recently, in a national colloquium in Uganda, there are eastern province of Uganda is reporting high occurrence of severe malaria, and even with very rare complications. Now there is a resurgence of black water fever. There is gangrene of the leg and of the arm that is occurring due to malaria in some of those places. But when we evaluated it, we also saw that there was such a heavy clientele for a very few personnel. Okay, so again, it takes us back to the prevention question, that it is better prevented than for us to run after it. So ACTs, for avoidance of that, for instance, here in Nigeria, we carry out our annual therapeutic efficacy testing, and so far, the results that we have show ACT efficacy that is still well above 95%. Okay, when all the treatment adjustments are made as they are supposed to be made. So ACTs are okay. That's the reason. Then, fundamentally, the shift away from chloroquine is that we have come to an understanding that the use of monotherapy, single drug, is always associated with resistance. If it is not today, it will come up tomorrow. It is a cycle that has happened over and over and over again, that we have made a fundamental shift to the ACTs. Even if chloroquine will find another use as we go on, because never say never in medicine, it's unlikely to just still be as an independent drug. I'm sure it will make a second coming in another capacity within the combination arrangement.
All right, thank you very much, Prof. And we've been enriched. I don't know if any of the other panelists have anything to contribute to that. Do you have anything to say? Otherwise, I'll move on to the next question. The next question on social media, Facebook, kindly explain on the most current malaria guidelines. So I don't know who wants to take that. Kindly explain on the most current malaria guidelines.
Okay. I don't know why they are falling under my purview. I'm the National Malaria Technical Director. So, all right. So, depending, because we are talking to Africa, this is not just Nigeria centric. Okay, so I wouldn't know the context of that question in terms of location. Okay, so what I'll do is therefore I'll answer it from WHO and domesticate it. So the WHO last published a guideline for malaria in 2015. Okay? But what they have done is that because WHO is responsible for a number of recommendations, they have felt that having one book on treatment, one book on vector control, one book on different aspects may be posing a burden of consultation to different countries. And so there is a fundamental shift again that WHO has carried out in now trying to warehouse all their recommendations into one location. Okay? And they are making it online such that every new recommendation will just be an update of that online version. So this time around, that document is going to be a living document, in which case, whatever you find there will be the state of recommendation as of that period. Okay. So that is an approach that is being. So if you talk about what is the most current recommendation, now recommendations are for different aspects of malaria. Okay, so but if it is on treatment, for instance, there is a recommendation. That recommendation is use ACT. Nothing has changed that. And there are several types of ACTs, but use ACT. Now, you domesticate that type of recommendation based on what your country recommends. So, in several countries in Africa, only one ACT is mentioned in their guidelines. But here in Nigeria, we have a primary ACT mentioned, which is artemether lumefantrine, as the primary ACT of choice. But our guideline accommodates all the other ACTs. The only ACT we don't use routinely is an artesunate sulfadoxine pyrimethamine combination, because we're already using the sulfadoxine pyrimethamine, quote and unquote. I don't want to use proprietary word name on this platform, but sulfadoxine pyrimethamine is used in many other things. That's the same drug we're giving to pregnant women. That's the same drug we're also using in our seasonal malaria chemo prevention. So it will not be appropriate to also be the drug we are relying upon when there is a breakthrough infection. Now, if you come to diagnosis, the recommendation is test before treatment. Okay? If you come to nets, the recommendation is use a net that is sensitive according to your insecticide resistance profile in your own environment. So the body of recommendation is large, okay? But if it's WHO, there is now a new guideline platform. If it is Nigeria, there is the 2020 updated fourth version of the guideline on diagnosis and treatment of malaria. That will be the latest. And I think that in other countries, Ghana, Kenya, Uganda, South Africa, they all have their own current national recommendations where their national peculiarities have been domesticated.
Thank you very much for the expansive explanation, Prof. Thank you very much. Without wasting time, I'll go to the next question, also from Instagram. Right. What is the correct dosage for artemether lumefantrine in children aged 10 months?
Okay, so the simple dosage for that, you have guidelines again that guides you, but as physicians, we normally dose according to weight and a few things like that. But simple rule of the two, it's one tablet of the 20 by 20 milligram by 20 by 120 milligram of artemether lumefantrine. Okay, just one tablet twice a day for 3 days.
Thank you very much. All right, the next question from Facebook. Why was quinine withdrawn as a drug treatment drug of choice? Quinine, why was it withdrawn as a treatment drug of choice? I don't know if any of the panelists won't take that.
When you have an authority,
From
there's
the
no point
authority.
putting around.
Okay,
Right.
thank you. So, specifically, the use of quinine was for treatment of severe malaria. Okay, and administration of it is a bit complicated. The conditions to be met are a bit challenging, and quinine by itself required a 7-day treatment course, and its tendency towards ringing sensation in the ears and a few other things like that. So a study was conducted and initially done in Southeast Asia that looked at artesunate versus, injection artesunate versus quinine in the treatment of severe malaria. That study is acronym SEQUAMAT trial, and it practically needed to be stopped midway because the difference between the two was large. But it was in an adult population, and the children population that were incidentally included in that study was not sufficient for a generalized statement, coupled with the fact that East Southeast Asia was an area of low transmission. So it became necessary to say, okay, if we come to an endemic area where children are the normal victims of severe malaria, will the effect seen in terms of artesunate over quinine, will it still be preserved? And so a very large study was conducted across 11 sites involving 9 countries that was called the Aquamat trial, that enrolled 5,420 patients, and it became clear that injection artesunate had a superior effect over quinine in mortality reduction as well as hospital stay and ultimate persistence of complications. And for every 40 patients or so that you treat with artesunate, you will have saved another life that will have died if you had used quinine. So based on that, in 2010, WHO updated recommendation and recommended injection artesunate as the treatment for severe malaria everywhere in the world. Okay? And it is superior. And because severe malaria is a condition of imminent death, you don't start it with inferior treatment. Wherever you have superior treatment, that must be your drug of choice in that instance. So let it be known that evidence was strong. So no matter how much attachment we have for quinine, it was inferior, proven in an 11-center multi-center study involving over 5,000 severe malaria cases. And I think every subsequent small study after that has continued to validate that finding till the present moment. Thank you.
Thank you very much for the lucid explanation. I'm sure we were educated as regards them, richly educated. I am. Right. To the next question. Any of the panelists can also take these. What are the early signs of cerebral malaria and the available treatments? What are the early signs of cerebral malaria and the available treatments?
Okay, so I'll take the signs of cerebral malaria from what the name says, cerebral, something that has affected the brain. And we had said the red flags, malaria, where the person becomes prostrate, cannot do anything, maybe loss of consciousness, irrational talking, the person doesn't respond, you speak to the person doesn't respond back to you, then you know that. But you can't say the person has cerebral malaria just by what you say at home, but you see the red flags and you send the person to the hospital. It is when the person gets to the hospital and the person gets a diagnosis of cerebral malaria. And the treatment is different depending on the age of the patient, which the doctor has to use his entire knowledge to decide what to do first. So the treatment of cerebral malaria is not something that the patient will do for the child at home or will do for the husband at home. It's something that will be instituted in the hospital, and it depends on what is found at that time. And it's a continuous management. So I can't say this is what the person will do, this is what the person will use. But what I know is that there will be definitely transition from tablets to intravenous drugs and other types of treatment. Thank you.
Thank you. I don't know if there's any addition from Prof to what Dr. Yutuni said.
No, that's okay.
Okay. All right. So, Prof, this question is for you, sir. It's from Kenya. This question is from Kenya. This person wants to know that a 7-year-old boy tested positive for malaria after 1 week travel to Western Kenya. The child didn't respond to artemether lumefantrine 2BD. The management was changed to artesunate 60 milligram, and he responded well. He wants to know why this is so.
Well, thank you very much. So you need to understand the context there. So Western Kenya has the highest burden of malaria in Kenya, and Kenya has 4 ecological zones of malaria because of the variability of its altitude. So a place like Nairobi is malaria free. So it's in Kenya, when you take that type of history, that was a very nice history that has been presented, because it's not different sometimes from somebody coming from another country entirely that is without malaria coming to an endemic country. So in Kenya, sometimes movement from highlands to lowlands is just exactly the same thing. And so you have somebody who is probably unimmune at all and who has been exposed. Number one, I wouldn't know what the parasite density was. Okay. Sometimes the parasite density can be a factor. If the parasite density is really extremely high, under our definition of severe malaria, we actually use, in a low transmission area, a parasite density greater than 100,000 parasites per microliter of blood. In a high transmission area, we use a parasite density greater than 250,000 parasites per microliter of blood as an independent criteria for severity. Okay. So what that person will have needed may be non-immune, rapidity of multiplication of the parasite. This thing goes pretty fast. It could have a very high parasite density, and it was important to first of all crash that with injectable artesunate before transiting to oral laxative.
All right.
Possible.
Okay.
I don't have all the facts.
All right. Thank you, Prof. And you have given us enough facts. You have told us lucidly about Kenya, and I'm sure my Kenyan brothers and sisters are also.
So the person must have gone to what they call Nyanza district.
Nyanza district.
It's Kenya.
Okay. All right. I'm sure they are richly, they must have gained from your perspective and experience. Thank you very much, sir. So the next questions. What measures can we put in place to help those with allergies to most of chemicals used in residue indoor spray, mosquito repellents, and treated mosquito nets? Those that have allergies to these agents. And what measures can we put in place to help those people?
So, well, it's a fairly complicated matter. There are two types of allergies. There are perceived allergy, because several of our people merely smelling and hearing of chemicals, they start reacting and they tell you they have an allergy. But there are true reactions also, which can be what we call idiosyncratic. You just cannot predict who is the person that is going to have it. If indeed somebody truly has all this, then we resort to physical measures. Physical measures in terms of environmental management, netting of the house, and how the person will also be on the alert. So if you are going out and you are going to be exposed to an environment where there could be mosquitoes, you need protective clothing. Wearing your dresses as longer sleeves or using repellents on outdoor. But if you're reacting to the repellent itself, then we just rely on using protective clothing, physical measures like netting of the house, and then being on an alert that I'm not sufficiently protected. So in the event of any fever, there is resort to testing rapidly so that any episode can be effectively treated.
Can I add something to that?
Okay.
Because this is a personal experience.
Okay.
All my children have allergy to any of the sprays. So I can't use any of the sprays. But we found a way around it. In that, if we're going to spray, then it's when we're all going out. So you can actually do your spray. Then before we get back, someone gets to the house and reopens and reventilates, the house. So by the time we come back, we've eliminated virtually all the smell. So most of the time, that is what we do, and that has solved it. Because once you give one spray, everybody starts coughing, and that's what I've had to deal with. Meanwhile, I can stay in the room and you are spraying it, and nothing is happening to me. But I think a lot of families go through that, and it's been a challenge. And like he has said, always wear long clothing and all of that. So that's another way to go about it.
All right. Thank you very much. I appreciate it. Quickly, Prof, this question is directed to you. Specifically,
From which country?
the country is not stated here,
Okay.
but it's directed to Prof. So, Prof, do we have false positive and negative with the rapid diagnostic kits?
Okay.
And if so, how do pharmacists know this and convince the patient on the results?
All right. Thank you very much. So maybe that is about the crux of the matter on RDT. Actually, there is a false positive, but it's a healthy false positive. What do I mean? That false positive is not because it is identifying something else. To put it very simply, the RDT system. So to put it very simply, the RDT detects what you call the bacteria, the parasite cell wall. So as I'm holding this device, imagine the cover is what the RDT detects. Now, if the parasite is dead, but is still intact as I'm holding it, you can be dead like this, just like a dead body is intact. Okay, the RDT will still detect it. All right, but there are some types of RDT that detects only a product that the parasite produces. Unfortunately, because of cost and storage logistics, that is not the type of RDT that is most common in use. The one that is most common in use detects the cell wall. Okay. So for as long as the parasite, though dead, is still present in the blood, then it can extend its positivity. So to that extent, RDTs are important in detecting the presence of the parasite, but may have limitation in monitoring response. Turn that around, you will then discover that the natural tendency for RDT is 1, identify the parasite, 2, identify the extended stay of the parasite. So when RDT is therefore negative, it is negative. If you get that perspective correctly, it is negative. The margin of false negativity with RDT is extremely low. Specificity for RDT, which is a test of negativity, approaches about 98%. So it's very low. And you need to, the only conditions that may happen for false negativity is something which we call HRP2 deletion. That is, this cell wall that the parasite is supposed to, the RDT is supposed to detect, sometimes may not contain the coded material that RDT is looking for as a genetic defect. But the occurrence of HRP2 deletion is particularly low. They've done a study in Nigeria, it's low. In Kenya, it doesn't exist. In Uganda, they have some proportion of it occurring, but none of it has reached a level yet to discredit the use of RDT. And what WHO recommends is that you monitor the level of that HRP2 deletion to see whether it may have any public health implication on you. So that's what it is.
Thank you very much, Prof. I knew you would do good justice to the question. Thank you, sir.
Thank you.
Now, viewers, for the last question for the day, what is the best regimen for both uncomplicated and complicated malaria in pregnancy?
All right. So, for uncomplicated malaria in pregnancy, the WHO recommendation today is for you to use ACT. ACT without any ambiguity in second and third trimester, okay, for uncomplicated. In the first trimester, we are currently as we are discussing, very soon reviewing that, and there will be a meeting later, I think next week, okay, where that issue will be laid to rest. All right. For now, we still recommend use of quinine, clindamycin in first trimester. All right. But if you look at the WHO guideline, even there it says that risk is considered significant. You can still go ahead to use your ACT even in the first trimester. But that will be settled after the meeting of that is coming very shortly. And I think before the end of this year, there will be a very unambiguous statement in that regard. For severe malaria, it is artesunate injection in all trimesters, because already severity is a risk factor of imminent death. And so any solution against death is always worth it. Okay. The reason why we talk of first trimester is because of something called teratogenicity, the likelihood of having babies born with malformation. Some measure of this was seen in animal models, but in terms of the register of accidental exposure to artemisinin compounds in the first trimester of pregnancy, we really have not demonstrated that in humans in over 3,000 exposures in the first trimester of pregnancy. So, but as I said, there will be unambiguity about first trimester of pregnancy before the end of the year. Second and third trimester, any of your ACTs, depending on the desired effect or the characteristics of the partner drugs. For severe malaria, unambiguously, all trimester injection artesunate is the anti-malaria of choice. But don't forget, as Yetunde said, in severe malaria, you have other treatment considerations. If the person is anemic, he needs to be transfused. If the person has kidney problems, he needs to be supported. If he has acute respiratory problems, he might need to be on a ventilator. So there are all sorts of supportive care that is required in severe malaria, all of which determines the outcome, not just the treatment of anti-malaria. Thank you.
Thank you very much, Rob. And sincere appreciation to all panelists. I'm sure viewers all over Africa have been enriched about malaria today. It's been a wonderful session. I have taken one or two things away from this webinar, and I'm sure that my African brothers and sisters have also done the same. Once again, I want to thank Professor Ayodeji Olugbenga-Mukuolu, the Nigerian Malaria Technical Director, National Malaria Education Program, for doing good justice to today's topic, and out of your tight schedule for making it here to educate Africans on the scourge of malaria. Again, I also want to thank one of our revered community pharmacists, Musumola Dusumu, currently the Assistant Secretary of the Association of Community Pharmacists of Nigeria, for also finding time to share perspectives and experience in community pharmacy with Africans today.
Thank you very much.
And lastly, our panelists, our respected Doctor of Preventive Medicine, Dr. Yetunde Oyalowo. We also thank you for finding time. I wouldn't know which country you flew in from to be with us today, but I know she's highly traveled. And I'm sure you also agree with me that she has shared lots of her experiences and perspective with us today. We thank you all, our panelists, and to the viewers, Africa. We thank you for listening. We thank you for watching. And I want to assure you that it's a monthly ritual. Next month, we'll also be coming up with another topic to educate us, and I'm sure we'll also bring in respected educationists across Africa to enrich our knowledge. So please watch out. We'll also reach out to you through different platforms when that time comes. So again, on behalf of management of Shalina, we thank you all for joining us today, for listening, and we look forward to rewarding times with every one of you. Thank you very much. Thank you.
Thank you.
Thank you.